Hi, so I'm Francois van Loggerenberg. I'm going to talk about some work that came out of the initial GLOBE studies, the results of which you've been presented with earlier today. So this was specifically a study to look at using Dialog Plus in patients with chronic physical conditions in primary care in the 3 original countries. And this is an extension of the setting in which Dialog Plus has been used. And it was extension work on the original GLOBE project. So the original collaborators with Queen Mary University were, of course, Bosnia and Herzegovina, Colombia and Uganda. And those countries all did, as you saw earlier this morning, earlier this afternoon, did studies on 3 resource-oriented interventions, psychosocial interventions for serious mental illness. During one of the teaching weeks, the second teaching week in London, the investigators discussed potential research ideas. And they realized that although Dialog Plus has been extensively tested in mental health settings, there's very little systematic studies on how Dialog Plus can be used in primary care. And because Dialog Plus is such a low-cost intervention, making use of existing and ongoing clinical meetings, there is the potential, therefore, that it would be particularly useful in low and middle-income countries where there are resource gaps. So the aims of the Dialog Plus in primary care study were to adapt Dialog Plus through a process of stakeholder consultation, refine the training materials, and to promote wider uptake and implementation of Dialog Plus, and then also to explore the feasibility and acceptability and effectiveness of Dialog Plus for patients with comorbid physical and mental disorders in primary care. In terms of the methods used, exploratory non-controlled trials were done in all 3 countries. At least 30 patients with chronic non-communicable diseases were recruited, and they were given up to 3 Dialog Plus meetings over the course of approximately 3 months in their routine clinical care. And sometimes the duration was a bit longer due to pandemic restrictions and the difficulty having those face-to-face meetings. In the course of the study, we also collected qualitative and process data, so interviews and focus groups about experiences of using Dialog Plus in primary care, but also looking at the number of sessions completed as intended, the number of participants recruited and retained. And that would give us a sense of what the acceptability and feasibility of Dialog Plus would be. To look at the effectiveness, we measured quantitative outcomes at 3 months after the 3 dialogue sessions. In terms of implementation across the countries, in Bosnia and Herzegovina, they were able only to recruit 25 of the participants. One of the participants didn't complete all of the intervention sessions, but all 25 were included in the analysis. In Colombia, 32 participants were enrolled, 2 were lost to follow-up, and 1 withdrew from participation, and so 29 patients are included in the analysis. And in Uganda, they recruited 60 participants at 2 clinics. 54 of those participants were able to provide follow-up data, and so included in the analysis for an overall number of participants of 108. In terms of the different clinical populations, so they were quite different in many ways in each country. Particularly noteworthy in Uganda potentially is a much higher proportion of high blood pressure and diabetes patients, and also older patients. That was the nature of the clinic from which the patients were recruited. So it is quite a broad range of conditions, and in 3 different countries using one intervention to see how it fares. In terms of the results, so the intervention was delivered as planned within the restrictions that were imposed due to the pandemic, and so we would say that it was successfully implemented. In terms of the acceptability and feasibility, qualitative data from Bosnia and Herzegovina is very encouraging, and what we found was that patients really liked Dialog Plus as an intervention. What they liked was it structures the conversation they have with the clinician to look holistically at various aspects of their life, something that didn't happen before, so the discussion wasn't happening. It also makes the discussion very patient-centered, because the patient gets to talk about their own satisfaction with all of these aspects of their life. And so it goes beyond just medication, as Hannah was saying earlier, and it goes beyond just care for the physical condition. The patients also felt that it increased a sense of empathy and understanding from the clinician, because the clinician now was actually asking them about various aspects of their life, not necessarily directly related just to the treatment they were receiving. The patients also felt that they could see real improvements in their life, and particularly because, as Stefan pointed out earlier, in Dialogue Plus, you identify various areas of your life that you want to improve your satisfaction with, and you agree concrete actions. And so in that activity, patients could see from meeting to meeting that things were really getting better for them overall. So they really felt a sense of personal improvement. In terms of the quantitative outcomes at 3 months, there was again a statistically significant improvement in subjective quality of life, symptoms of anxiety and depression, an improvement, but not a statistically significant one, in objective social situation. And again, as has been mentioned in the other talks, the effect sizes are very large, much larger than we would see in trials in the UK, for example. And so these are very important and significant improvements. So the conclusion then about Dialogue Plus in primary care is that it can be used, it can be implemented and used successfully. The sessions were mostly completed as planned. The patients were very positive about the experience of using Dialogue Plus. There were overall very significant improvements in the quantitative outcomes with some very large effect sizes. Again, I think for the reasons that have been mentioned in the other talks. And so Dialogue Plus does appear to be an attractive option for use in primary care, given that it is such a low cost, very flexible, and has been seen to be effective in so many different settings. And I think the main lesson from this is just we need to approach our patients differently and have these conversations differently. It's not just about physical care, but also about other aspects of life satisfaction. Thank you.